All right, welcome. I'd like to welcome and thank you for joining us tonight. We know you have a choice in air travel, and so we appreciate that you're flying with us and not with someone else. Our program today is entitled Deep Remission, Top-Down Treatment Strategies and Real-World Data in Patients with Ulcerative Colitis, an interactive and innovative case series. We're really going to focus tonight on ulcerative colitis, and we've decided for the sake of time that we're going to primarily focus on biologic therapy and parsing through different biologic therapies and the rationale for why. I'm Maria Abreu. I'm at the University of Miami. I'm a professor of medicine there. My disclosures are on your iPad. I'm very much looking forward to interacting with my wonderful colleagues, Dr. Asher Kornbluth, who's a professor at the Mount Sinai School of Medicine, and Dr. Miguel Reguero, who's head of the IBD program at the University of Pittsburgh. We have 3 learning objectives for today's program. Oh, sorry about that. To differentiate between disease activity and disease severity to drive treatment decisions in patients with ulcerative colitis. In other words, trying to understand a patient's prognosis rather than just focusing on what's happening at that moment in time. The second objective is to apply the unique risk-benefit profiles of different biologic therapies when making treatment decisions based on individual prognosis and severity of disease. And finally, to utilize data from real-world studies on the use and effectiveness of biologic therapy for ulcerative colitis to initiate early, effective treatment for patients with UC. So the first case is one of mine. And you'll see from the way that we've written the cases that really there are multiple answers, and we really want to have a thoughtful discussion of how we make decisions about the various choices that confront us. This is a 21-year-old man with ulcerative colitis who was diagnosed last year. He needed steroids at presentation and again 6 months later. He's on mesalamine, 4.8 grams a day, but often forgets to take it like many of our college-aged patients. He's now flaring with 6 bowel movements a day with blood. He gets up twice at night and is leaving class because of urgency. His colonoscopy shows a Mayo 2 to the splenic flexure and a cecal patch. He is C. diff negative. I started him on prednisone at 40 milligrams, and within 2 weeks he's down to 4 bowel movements a day, less urgency, able to get to class. We also do some routine testing for various things, and he happens to be EBV IgG negative. So this is his endoscopy, and I think you can see it here. His terminal ileum is normal. He has that bit of inflammation just around the appendix that I've certainly seen patients be told you have Crohn's disease, when in fact it's this cecal patch that we're familiar with. And you can see that he's got a Mayo 2 with friability and shallow ulcerations on the left side of his colon. So we'd like to hear from you. What would you consider next for this particular young man? Would you start him on azathioprine, infliximab, adalimumab, vedolizumab, or get him to take his 5-ASA? All right. So a lot of a good distribution. I think some people just want, the majority of people want him just to take his 5-ASAs. What do you think, Miguel?
So I think this represents a difficult case that we see quite commonly. So you've had him on prednisone for 2 weeks at 40 milligrams, and he has pretty severe, moderate to severe disease. While I think it's reasonable to try to have him become adherent, the reality is that he's already shown that the mesalamine is probably not going to be enough. He's having nocturnal symptoms. You've moved to a steroid. Interestingly, when you look at the azathioprine answer, while I don't disagree with that, I think Maria threw us not a curveball, but he's EBV negative. And there's a concern that especially in young males, if they have acute mononucleosis with EBV, that can cause hepatotoxicity, splenomegaly, low platelets, and there's this syndrome that we see that can be lethal. And if you've seen it before, and I've had a couple of patients like this, you won't want to give azathioprine in this setting. So then this really leaves us with 3 of the biologics, infliximab, adalimumab, vedolizumab. And I think I see 14% from adalimumab, vedolizumab, 22% for infliximab. I don't think any of those are incorrect. I think now in the era of looking at risk and benefit in a young man, EBV negative, I could make the strong argument to start them on vedolizumab from the start as the first biologic. We can get into insurance and whether or not that makes a difference. I would say that any of those three are correct, but vedo would be certainly a very reasonable first step.
Oh, sure. Anything to add?
Yeah, I would definitely stay away from just encouraging adherence to 5-ASA. He sort of showed he's not going to do it. Even if he did it his whole life, he's at this point not getting better adequately on prednisone. And my rule of thumb is if you're going to get better on prednisone, you're going to have dramatic benefit by 7 to 10 days. At 14 days, he's still staggering along. I don't want to just continue him on prednisone. If I'm not going to continue him on prednisone, he certainly doesn't have time for azathioprine, whether or not you're going to worry about the mononucleosis, EBV, IgG negative.
Right.
That's a separate debate. We're evolving into thinking about that. But I don't think he has time for the azathioprine to work. So now you have a chance to have this, and it's not just a buzz phrase, shared decision-making, because this patient is not so severe that there's one best answer. So I talked to this patient about using the anti-TNFs. He's not so dreadfully ill that he's in the hospital, and I feel compelled to start with infliximab. Here I think infliximab or adalimumab are reasonable choices. But then I had the discussion that you're not quite so sick, and if we want to avoid the thinking about opportunistic infection and that dreaded word lymphoma, even though it is quite rare, then there's vedolizumab. And then the patient will say, well, I'm voting for vedolizumab. And then you say, yeah, but that's an IV infusion. That might tilt them back away from it. So there's these variables you have to consider. One of them is convenience in terms of sub-Q, and the only one we see here is adalimumab. And then the other is efficaciousness in terms of infliximab, probably being more effective in the sicker patient versus vedolizumab without the toxicities we associate with the anti-TNFs.
Right. Well, maybe a little bit later we can get into sort of the timing of how long some of these drugs take to work, Asher, as we explore all the different options. All right. So I want to talk to you a little bit about the pathogenesis of ulcerative colitis because I think it's going to inform how some of these biologic drugs are working. You know, until we could start rolling, guys. Until just the other day, we had anti-TNFs, or a third anti-TNF to choose from. So you've been to many of these dinners. All of our BMI has probably gone up as a result of all the different anti-TNFs that we have to choose from. But let's just remind ourselves of some of the pathogenesis of IBD. I'm going to get up because I only have one pointer. And what you can see in this infographic is here's the colonic lumen full of bacteria. There are some of the cells of the immune system that are actively sampling bacteria that's in the lumen and using that signal to activate T cells in the lamina propria of the intestine. These T cells then become effector T cells that secrete cytokines that have inflammatory effects and can damage the lining epithelial cells, allowing more of these bacterial antigens to get into the lamina propria and activate macrophages through both macrophages and dendritic cells, producing other inflammatory cytokines. But you can see that we're not just dealing with TNF-alpha as the one cytokine that's being produced that causes harm, but clearly TNF-alpha is one of many important pro-inflammatory cytokines that can be targeted. And already on that slide, you know, you're aware that there are other drugs that are targeting other cytokines. Another way that one can approach the treatment of IBD is trying to inhibit this process. What this is showing you is a white blood cell. It could be a monocyte, it could be a lymphocyte. These lymphocytes are in the circulation in post-capillary venules. In the case of the gut, this is happening in the lamina propria. And they're rolling along the surface of the blood vessel. These blood vessels, when there's inflammation going on down here, overexpress these adhesion molecules and allow the cell to stick, these white cells to stick to the lining of the blood vessel. One pathway is the CCL25 pathway, but for the purposes of tonight's discussion and vedolizumab, I'll call your attention to the fact that alpha-4 beta-7 is expressed on the lymphocyte or monocyte, and it binds to something called MAdCAM. When that binding occurs, then the cell can get into the intestine and cause, in the case of an ulcerative colitis patient, ongoing inflammation. And so fundamentally, there are cytokines that are produced locally that have an inflammatory effect, a damaging effect, and there's recruitment of cells to the intestine that can also then, of course, beget more inflammation. And you can actually download these infographics maybe in the next couple of days. Miguel, I'll turn it over to you.
Great. Well, thanks, Maria. So in my part, we're going to start to enter into the discussion about disease activity and disease severity and looking at different biologics in terms of some of these outcomes. Let's consider for a minute, and there are these AGA ulcerative colitis care pathways. And if you haven't seen these before, some of our electronic medical records and systems are now requiring that we follow pathways or guidelines. And this was published in 2015. So there's a risk assessment that we do for ulcerative colitis, which takes into account inflammation, comorbidities, the colectomy risk, what our initial therapy should be, and then ultimately what treatment options we have in terms of exacerbation and optimization. And this has all come together for this clinical decision tool. I actually have the app on my phone, and they continue to update this regularly. This is a key slide, and I think there are several take-home messages on this. So for discussion of our case and the case that you're about to see, you probably do these decisions in your offices every day. So consider for a minute the low versus high risk, age of diagnosis. We know that younger patients tend to have a more aggressive course of disease. We know that more extensive pancolitis, maybe unlike the case that Maria presented, which was left-sided, but the pancolitis patient has more severe disease. High C-reactive protein sedimentation rate. If a patient requires steroids as their first treatment, this has a higher rate of disease and severity. Probably the number one factor in terms of severity, and the take-home point from this single slide is if you see deep ulcerations, deep ulcers in the colon, this has a high rate of colectomy. And I would equate that this is a high rate of somebody who should go on a biologic early. So if you're wondering, should you use steroids and 5-ASAs, deep ulcerations make a difference. Unfortunately, C. diff has become an epidemic, and we now see that patients with C. diff have more refractory disease, often leading to colectomy. Certainly if they have a history of hospitalization, high risk, and CMV. So this can be a very quick checklist for you to decide who might need surgery, but also who may need that biologic. So let's consider a different case. This is a 34-year-old female, recently quit cigarette smoking, which I think we all know the association with smoking being protective for ulcerative colitis, who comes in now with 2 months of symptoms. She has 10 to 15 bloody bowel movements a day, rectal urgency, tenesmus. She's anemic with a hemoglobin of 10.8, and her C. diff is negative. A colonoscopy is performed, and you see ulcerations and inflammation from the rectum through the entire colon to the cecum. And unlike Maria's case, the entire transverse and right colon are involved. So when we think about this case, the question is, what should be the goal of intervention? So think about your practices when you answer this question. What's your goal of intervention? Symptom improvement, mucosal healing, histologic involvement and improvement, or a combination of these factors, or is there something else you consider? So take a minute to think about this, and then we'll discuss this as a panel. All right, so unlike the first audience response, we see an overwhelming 87%, a combination of a goal for intervention that would include symptom improvement, mucosal healing, and I'm actually interested in hearing from the panel about histologic improvement. So Asher, let me ask you, what are your thoughts on the response, and what are you doing in your practice?
So I think we all recognize if we're getting mucosal healing and histologic improvement, we've had symptom improvement. The problem is, I'll go into a little later, we see symptomatic improvement, and the disparity is we don't get that mucosal healing and histologic inflammation. But almost by definition, it's rare to see a mucosal inflammation that's healed with histology that's normal and a patient who's still symptomatic. I think the point there is that patient doesn't have UC symptoms if they're still having diarrhea, and that's a patient you should back off and maybe treat for IBS. But in terms of what we're looking for, obviously symptom improvement, obvious. In terms of mucosal healing, all the studies we have so far, we're now looking at mucosal healing as an endpoint. The FDA is actually demanding that for all oncoming trials. Histologic improvement is probably where we're going next. 10 years ago, we used to have all these debates at the meetings. Is mucosal healing important? Should you shoot for it? Now that debate is closed. I think we're going to start moving towards, should you shoot for histologic improvement? Every study that's looked at it, not surprisingly, finds that those patients that have total histologic healing, defined albeit by many different scales. Those with histologic healing do better in the long term.
Right.
Maria, do you want to add anything?
I agree with that completely. I think we believe these are aspirational goals. Who would not want to have mucosal healing and go as far as histologic healing? But I think, we could debate about whether we optimize therapy to achieve that in a patient who's otherwise well and has had mucosal healing to get that histologic healing. But I'd make the point that more and more, and I wonder if you guys see the same thing, these patients of mine that are on biologics that have been well for a long time, their histology becomes completely normal. Mm-hmm. We're not even talking about no neutrophils and no extra lymphocytes, like normal, no architectural distortion. I can see that they have a pockmarked pseudopolyp E. colon, but when I send them the pathology slides, send the pathologist the tissue, they tell me this is normal intestine. That's really a testament, I think, to what is achievable, and that probably takes a bit longer. My own hypothesis is that kind of regeneration and normalization at the level of the architecture of the gut will take the longest to achieve, but will ultimately probably translate into very low risk or no increased risk of colon cancer, I should say.
And Matt?
Go ahead.
Yeah, no, that's an important point. And I actually put up on this slide the definition of mucosal healing. And as you can see, this includes histologic improvement. To Maria's point, 2 take-home messages on histology. One is that if there's still histologic activity, there probably is an increased rate of dysplasia and potentially neoplasia long-term. The second, out of the scope of the discussion tonight, is this may be something we use in the future to predict who can stop treatment and who continues. That's not what we're going to discuss tonight. But why, in the effort of time, let's go on, and then Asher, I'll come back to some of your thoughts as well. So ulcerative colitis, we've already addressed, and most of you saw and seen this and actually responded quite nicely. Better correlation of symptoms to mucosal inflammation has occurred in UC, because an inflamed rectum is often what causes most symptoms. Most of these patients have bleeding, tenesmus, and diarrhea. The difficulty with ulcerative colitis management is that what do you do when there's incomplete healing of the mucosa? And the decrease in mucosal inflammation often leads to decrease in symptoms, but how much should we look to achieve? 100%, or is partial okay? And you've heard some of these talks at DDW this year. So this is our current thought, and I think Asher brought this up to begin with. Yes, we care about symptoms and improved quality of life, but we're now really moving to remission, and we're looking at deep remission, which includes histologic healing, which we know minimizes surgery, hospitalization, and importantly, as Maria said, surgery. So the challenges are the symptoms that we see may be nonspecific. So sometimes we do a scope and somebody actually has healed bowel, but they might have irritable bowel causing some of the symptoms. The symptoms also may not reflect the extent of disease. So some of the worst patients are proctitis only, where if you heal their rectum and their colon's inflamed, they actually may feel quite well. And there are many patients who accept living with disease activity. They've gotten used to 4 to 7 bowel movements a day. Obviously, patients don't like endoscopy or colonoscopy as it's invasive, and sometimes symptoms can lag behind. The majority of IBD patients, interestingly in clinical remission, looking at historic studies, actually have some degree of histologic or endoscopic inflammation. I think this is an old study, but now with better treatment, we're able to heal better. So what are some of the predictors? And again, this is, I think, a no-duh to all of you in the audience. If you saw this on a colonoscopy, 1, you'd probably be calling your surgeon. But 2, if you're thinking about medical therapy, you're beyond the steroids and the prednisone at this point. And I think that's really the key points of these deep ulcerations. We know that endoscopic severity correlates with colectomy. So on the left-hand blue bars, deep ulcers, 74% of these patients in the pre-biologic era went on to colectomy, whereas less severe inflammation in the red bars, still there was 23% colectomy, but not those very high rates. We also know that mucosal healing at 1 year is associated with lower rates of colectomy independent of symptoms. So this is a theme that we're seeing over and over. So let's get back to our case, and maybe Asher, I'll start with you when we get into some of the discussion. So despite prednisone and mesalamine, the symptoms in this patient progress. She has pancolonic disease, you try her on azathioprine, she says bad nausea, vomiting, she doesn't want to take it, and now her disease is severe. let's get the audience response, but Asher, I'll start with you. What would you do in the audience? Would you escalate her mesalamine? Would you give her infliximab, adalimumab, vedolizumab, or would you send her right now to a colectomy? So go ahead and take a second to answer that, and then Asher, we'll get your thoughts on that as well. So unlike the first set of answers, I think we have more of a majority here. So 60% of you would choose infliximab, 14% adalimumab, 20% vedo, and smaller for colectomy and escalation of mesalamine. Asher, do you agree?
Yes, I do. I mean, this patient has bad markers. You heard about the difference between disease activity and disease severity. This is a young person. This patient has pancolitis. This patient hasn't budged on steroids. Here I would lean heavily towards infliximab. You could have, again, the discussion about vedolizumab. I think we have more evidence for the really sick patient, but again, that's sort of a biased, non-proven view. There'll probably, not in the next few years, be a head-to-head study, but I think most of us would lean towards infliximab in a patient with such bad markers. What do you folks think?
So yeah, Maria, and actually curious when you answer this, also your dose of infliximab, because that comes up quite a bit.
Sure. I think the thing that needs to be highlighted is that, you know, vedolizumab is highly effective, but it takes a bit longer to work. And so in a patient like this, you'd have to be contemplating transitioning or having a bridge therapy. You know, there are various people doing studies on this. I think you guys at Sinai, right, Asher, are doing steroids as a bridge. Not everyone wants to be bridged with steroids. Others are exploring cyclosporin as a bridge, a short-term thing that can be given as we transition to vedo. So if you want to have one-stop shopping with one biologic, I agree with infliximab. And one of the things that we do routinely is for someone who has high CRP, has very active disease, I start out of the gate with 7.5 milligrams per kilogram of infliximab. I can't get insurance to approve 10 milligrams per kilogram out of the gate. I can do it in the hospital, but if they're outpatients, I can't get it approved a priori. And then I check trough levels before their first maintenance dose. So I don't alter that therapy, that 7.5, until they're well into maintenance therapy. But the idea, I think, that we're learning, and certainly this is extrapolatable to the anti-TNFs, it's not as clear for the adhesion molecule strategies, is you have to hit them hard early to get the best response, and then you can de-escalate a little bit later on.
So I think all of you agree, and this is what happened with this case. The patient went on infliximab. We actually do now more routinely start 10. Maybe we're lucky in Pittsburgh, we get insurance approval. And we actually de-escalate based on trough levels. But nonetheless, she does very well. You repeat a colonoscopy, and there's significant improvement, but there's still this slight mucosal inflammation with histologic inflammation. So Asher, coming back to you on this point, what would you do now?
So I think there could be good people could agree to disagree about what starting dose, what level will you shoot for? Should you do proactive or reactive measurements of anti-TNFs, and when do you do that? I think a very low albumin is probably the best marker that you're going to need a higher dose out of the gate of infliximab. Go straight, probably 10 milligram per kilogram. The data about what do you do in the very sick patient in the hospital, where you're sort of desperate, you want to get them well really quickly, do you put them on 10 mg per kg? Data is very soft on that. There's not real good randomized controlled trial data. But if you have a patient who's real sick and a very low albumin, I would move towards a higher dose faster. This patient, again, has a bad prognosis going forward. We've talked about what Miguel talked about in terms of disease severity. So I wouldn't be satisfied with these markers that still tell me the patient is at a higher risk for hospitalization and colectomy. So this is a patient I would really try hard. How would I do it with this patient? Check trough levels and move them well into a therapeutic range, and we could have a discussion about combination therapy in the UC patient, but I think really what we're shooting for is well into the therapeutic range of infliximab in a patient like this, and I wouldn't leave a patient like this.
So I think this is a great segue. I'm going to give you the clicker and let you go ahead.
Okay, so we've touched base on the ins and the outs, the advantages of mucosal healing, and why should we incorporate it? I think we touched on this most of all. It's not disease modifying. Our older drugs, the 5-ASAs, even azathioprine, when we looked at long-term outcomes, we don't have real good data that it influences long-term outcomes as we have with the anti-TNFs. And we've been making historically decisions based upon saying, and my mentor, Dan Present, may he rest in peace, used to say, if you want to know how patients doing, say, how you doing? And that tended to work if we didn't want to do sigmoidoscopies. Dan was still doing barium enemas in UC till very late, but we now know that that's a very antiquated way to practice and not ideal at all. We should not be making symptoms based on symptom control. We also have to parse out elements of IBS if the patient's having no bleeding, and we want to make adjustments based on hard data, namely mucosal healing. So seeing is believing. Symptoms, as we just said, are nonspecific. And we do have, from every study that's looked at it, retrospectively even, of randomized controlled trials like Act 1 and Act 2, the pivotal UC and fliximab studies. If you achieve mucosal healing, you're much less likely to need hospitalization and surgery, and probably with histologic healing, not so much, the data's not quite so there with mucosal healing, but with histologic healing, it seems really increasingly strong evidence that you reduce the risk of long-term dysplasia and cancer. So this, again, is not a buzz phrase. This is really shared decision-making, and we're going to have to do more of it because 3 days ago, the New England Journal of Medicine had yet another new agent, not truly a biologic, tofacitinib, a small molecule. That's another drug out there that you're going to have to discuss with your patients, risks and benefits, costs and potential side effects, some of which we don't see in the medications we have so far. So in RA, they look not to say to the patient, how are you feeling? How do your hands feel in the morning? How do your knees feel after ambulating? They actually do joint counts and follow-up measurements. And we're moving towards this, and Jean-Fred Cohen-Bell, and I urge you, that's maybe one of the most important presentations at this meeting in terms of how we're going to look to treat patients going forward, is taking this treat-to-target approach. And don't confuse it with looking at drug levels. That's sort of a corollary. Treat-to-target means we set a target that we want to achieve with the given medication we have and shoot for that. And again, that's achieved by knocking out the inflammation, and we want to measure disease activity in, again, an objective way. Symptom control is not good enough. So we've talked about we want to induce remission, we need to maintain remission. Steve Hanauer is very fond of saying you can't maintain a remission until you induce a remission. You can't go to a maintenance dose if it's in fact lower until you prove you've induced remission. We want to minimize long-term toxicity, and in large part, as you'll see in a few slides, that's not avoiding biologics so much as avoiding steroids. And obviously, achieving all of this will enhance the patient's quality of life. And again, mucosal healing is the important objective endpoint, avoiding complications. Okay, so getting there, we have a number of medications. That list is ever expanding. And so I'm going to turn it back to Miguel to talk about what we have available now.
So I think one comment I'll make is it's interesting in both cases, the first vedolizumab was probably the higher percentage in infliximab for the second. So why we position that, and let me go through some of the medications we have. So these are currently the 4 biologic medicines approved for ulcerative colitis, and you've seen them use these before. Infliximab, adalimumab, golimumab as anti-TNFs, and then finally vedolizumab is the newest biologic agent. So our goals are really to look at induction of remission and maintenance of remission, as Asher has already said. And before we can induce remission, we have to actually have them on some control of their disease. So one of the options is for severe UC, as in the second case, would be the anti-TNF, and in this case, we picked infliximab.
So I think here, Miguel, this is, if we could go back to the video. I just wanted to highlight, you mentioned already
Sure.
that we have 3 anti-TNFs. We have 1 anti-adhesion molecule strategy approved for ulcerative colitis. And so I just wanted to kind of describe to you graphically how that works. If you guys could animate that. Yeah. So I think you saw this in the last infographic, that it's cytokines and macrophages that are producing inflammatory cytokines, but especially macrophages making TNF-alpha. TNF-alpha has a variety of effects on many cell types and can directly induce intestinal damage and ulcerations. You can already see IL-12/23, the target, of course, of ustekinumab. These are regulatory T cells. We'd like to increase that. But currently, the therapy is blocking TNF-alpha wherever it's produced with these agents. The other strategy is to try to inhibit adhesion molecules. So here are red blood cells. Here are white blood cells. The white blood cells are rolling along the mucosa. They stick in the gut because of MADCAM and because they're expressing alpha-4 beta-7 on the lymphocyte. And vedolizumab is an antibody that blocks that interaction very specifically, so that it's very specific to gut homing T cells. I'll turn it back to you.
So we know that the infliximab data, I'm going to go through these kind of quickly because I think you've seen this probably 1,000 times already, are the Act 1 and 2 for both clinical remission, Act 1 in clinical remission, Act 2 for severe UC using infliximab. Adalimumab, similar at week 8 and 52, and you can see placebo on the left-hand side of these bars in dark red, adalimumab in the lighter orange for both week 8 and week 52 in the combination, showing a statistical benefit of adalimumab over placebo. Similarly, golimumab, same story for the most part, especially at the higher doses that we use, a benefit in terms of induction for moderate to severe UC. Also for golimumab, maintenance of remission has shown a benefit for moderate to severe UC, I apologize, over placebo. It's your electric personality, Asher.
It's my shocking personality.
And then finally, vedolizumab. So vedolizumab in blue for clinical response, clinical remission, and mucosal healing, a statistical benefit for vedolizumab at each of these three endpoints. And then finally, the primary and secondary endpoints through week 52. And Asher's going to show you something interesting with vedolizumab. This seems to really stick and hold. So not only through week 52, but Asher will get into the vedolizumab long-term data, and some of that's in a table in your backup slides as well, where we actually see these high rates of continued response, and there's not the drop-off that we've seen with other agents. When you look at the totality of all of the biologics on the left-hand side and the line of unity, that line running up and down for one, left is favor placebo, right is favoring the biologics. Aside from the first adalimumab study, all of them show a benefit in terms of attaining mucosal healing. So clinical response, remission, and now we're seeing mucosal healing as well. Similarly, not only in the induction mucosal healing data, but the maintenance data looks good in terms of mucosal healing. And I think the other aspect, we're not talking about trough and levels tonight. When you heal the bowel, often your level of drug becomes higher. And probably to maintain remission, especially mucosal healing, it's easier when the bowel is not inflamed. That's an intuitive statement, but I think it's important to make. So induction and maintenance therapy in high-risk patients. This is just an overview of an algorithm to consider from the clinical pathways from the AGA that, again, you can pull this up on your Palm Pilots or your smartphones. I'm dating myself by saying that.
Goes with the music.
Yeah, that goes with BlackBerry. So the induction therapy, short course steroids with initiation of thiopurine, we didn't talk about that much, but maintenance, again, if you have a patient who goes in remission with thiopurine, it's okay to continue to use that. However, if they require anti-TNF with or without thiopurine, vedolizumab with or without a thiopurine or methotrexate, that's the maintenance strategy for them. If you have a patient on an anti-TNF and a thiopurine, and by the way, I will say, right now, today, I am still using combination therapy with an anti-TNF. At this meeting, there's a lot of discussion about this, but right now, I still use an immunomodulator when I start an anti-TNF, and that's not necessarily true with Vedo, which may be a bit different. However, for purposes of this slide, we do show Vedo plus minus immunomodulator. One caveat is if Vedo is your second or third biologic and you've had antibodies formed to others prior, I will use an immunomodulator with Vedo. However, in Maria's first case, where we use that as the first-line treatment, I'll use vedolizumab as monotherapy. So that's a distinction for me in my practice. And then obviously continuing maintenance. If they are not achieving a remission, we need to change strategy. And we can get into some of the nuances, whether we switch out of class or somehow optimize within class. So in summary for my section, anti-TNFs and vedolizumab are effective not only for induction and maintenance of remission, but in the bullet point 2 are also effective for mucosal healing. We all know, and we've seen this, and DDW this year has talked about this as well, Earlier use prevents complication long term. So whatever strategy you use, and I tell my fellows this, use a 3 to 6 month rule. If something's not improving by 3 months, make a change. Don't wait, don't linger. I think we need to either optimize treatment, check levels, or do something different at that point. And then my final point on that was that surgery is not a failure. And I apologize for the feedback, but the surgery, if you have a patient that sick, failing treatment, failing biologics, surgery is an acceptable alternative, and I think we need to refer them earlier.
Okay, so I'm going to talk about biologics in clinical practice, real world experience. In other words, you have the patient, they're on the medication, you say, well, I don't have long-term prospective controlled trials going out 3 years or 5 years, but there are good data looking at what happens to these patients from the randomized controlled trials. And I think this is better than looking at random series that are reported from one center, from one country, where things are done very haphazardly. These are randomized controlled trials where the patients come out of the trial after a given protocol, and now they can go looking forward on different regimens, but they're looked at in a regular way. And we will look at the various drugs, but I think the best piece of information I'll give in this portion is remembering what the predictors of badness is, of IBD-related ED emergency visits, hospitalizations, and high cost. And thinking about it while we're up here, I just thought about, and tell me if you guys feel different, once a patient has established inflammation, in fact, whether it's UC or Crohn's, I've never seen a patient come to me where the biologics were started too early. Just never seen that. And often, and very often, patients, they've waited too long, they've been on steroids too long, bowel damage has occurred, but I've never seen a patient who had biologics started early, and that was the mistake. Similarly, as a correlate to what Miguel said, I don't think I've ever seen a patient with UC who had a total proctocolectomy when they shouldn't have had. In other words, it was too early, we didn't start too many medications. A total proctocolectomy with ilioanal pouch is really not a failure. A failure is to have a patient fail multiple medications, incur multiple side effects, and not think that surgery is the right thing. And here we see and you'll see many factors here that are predictors, but the only ones that we can influence are our prescribing, and it's either steroids or narcotics. And there's a very good registry called the TREAT registry, now well over 5 years, over 5,000 patients. What was related to increased risk of infection and mortality was not an anti-TNF, but either being on steroids or narcotics. So in terms of long-term extension studies, I'm going to show you data from Act 1 and Act 2. These were the pivotal trials of ulcerative colitis using infliximab. And when you came out of the study on the left at 52 weeks, and you were continued on this throughout another 1 year, and these data stayed stable over the next 3 years, you see that about 80% remained in remission. So once you've identified yourself as a responder or remitter, you're very likely to do well over the ensuing years. Similarly, or conversely, if you come off infliximab, and we've seen more data probably about discontinuing biologics in Crohn's, but the same story holds in ulcerative colitis. If you come off infliximab and you're just left on 5-ASA, about 80% of those patients are going to have a relapse, and sometimes a relapse bad enough to require surgery, because again, you've identified a severe group of patients. If you take a patient off infliximab, the best strategy was leaving the patients on 5-ASAs and thiopurines, and probably the important play there is the thiopurines. But in fact, we could talk about this. There's no data anywhere in any randomized controlled trial that thiopurines are more effective than the anti-TNFs, and there's no data to suggest they're safer. So we have a less effective class of drug with higher risk of lymphoma. So using a thiopurine as your remaining drug after you have combo therapy, there's not much really going for it other than cost. Here's the same story with open-label adalimumab, maintenance of remission in ulcerative colitis for 3 years. These are patients coming out of the randomized controlled trial. And if you came out with a response or remitter, again, about 80% of patients remain well at 3 years. Vedolizumab, again, similar story. If at year 1, 52 weeks, you came out and you were in response, going out now to 3 years, and this data has been expanded to 5 years, patients continue to do well. Here, about 90% of patients remain well. If you've identified yourself as a responder or remitter to any of these biologics and maintain that out to 1 year, you've probably healed your mucosa, and you've identified someone as looking at Maria's mechanisms, that was the active mechanism of action, and you've shut it down. Now, this goes to what happens if your patient responds to vedolizumab and then loses that response, and you want to increase the dose or shorten the interval. Now, the chief limiting factor to this in the real world is insurance, and it's hard to sort of sneak it in. Sometimes I sort of give them Q6, hoping the insurance company doesn't notice, and I sneak it in Q5, Q4, and I try and squeeze it tighter and tighter. In the Gemini 1 and 2 trials, patient who fell out of response or remission, they were able to get Q4 week. Here you see that patients who lose their response were able to get the drug again, and you re-achieve response. And these are patients who are either TNF antagonist failures, and those obviously won't do quite as well. They have a more difficult phenotype, but especially in patients who had been anti-TNF naive, you will regain a response in treating these patients. So our goals are, I think this will summarize, mucosal healing is an important, and I would say essential clinical endpoint. Patients can be in clinical remission and still have evidence of active disease, and I don't think we've succeeded in treating that patient for the long term. Treatment strategies should extend beyond symptomatic remission, which is clearly inadequate in this day, and we're looking to promote mucosal healing. A couple of years from now, we might say, well, there's sufficient data to say everyone should get histologic healing. I wouldn't push into a new drug class based upon mucosal healing with residual histologic inflammation. And the biologics are an important component in promoting mucosal healing, and you see varying degrees of efficacy, clinical remission responses, sustained remission. And you're going to see now reports that the most important or the most expensive component of IBD care these days has become the anti-TNFs. But that does not factor in that you're using this more expensive drug and dropping down, by nature of that, the cost of hospitalization and surgery. So that's important to keep in mind. Don't be dissuaded from using biologics when it's appropriate because of, quote, the costs. Remember, we're driving down hospitalization and colectomy thanks to the biologics.
But we've gotten a lot of questions, and a lot of great questions. All right, so I'm going to start with Miguel. What are your biggest side effect concerns with anti-TNFs or Vedo? Miguel,
right.
What do you say to your
The
patients?
biggest side effects concerns with anti-TNF in my mind are more the infections than anything else. I think the story in terms of lymphoma, the story in terms of the cancers, and the story in terms of the squamous and basal cell skin cancers, it's very rare. So for me, it's infection. The nice thing we've seen with infliximab and adalimumab, golimumab for UC, if they've done well for a while, we've seen long-term success in terms of very low rates of infection. In terms of vedolizumab, fortunately, to this day in my clinical practice, we've seen very little side effects. The 3 side effects that we've seen that are fairly mild and transient are some nasopharyngitis, which is usually somewhat limited, but alpha-4 beta-7 is in the nasopharyngeal area, so some patients complain about that. If you were to do liver function tests, some of them will have a transient rise in their LFTs, and I tell my patients, sometimes they go up, but usually without doing anything, they go down. The one that's probably the one I warn my patients about, but it's fairly mild, usually well tolerated, are arthralgias. So some of the patients, especially when we start, and whether it's they're coming off of steroids and that's the reason, or they've switched from another agent, arthralgias can be a component. But not lymphoma, not infection, not bowel infection. And there are many studies here at DDW looking at the safety of Vedo, and I think it really bears that out.
Right, great. Asher, do treatment-naive patients do better on biologics?
Yeah, I think every trial you look at, they do better. It's not surprising. You're selecting out a patient traditionally who you might have put on a biologic, and now you think is not so sick, on an anti-TNF, and now you think that patient is not so sick as to need that. And every trial has basically found that an anti-TNF naive patient does better in UC would be with Vedo than if someone has already failed an anti-TNF. Now remember, there's different reasons patients fail an anti-TNF, and before you say an anti-TNF patient is a failure or the anti-TNF has failed the patient, is you want to make sure you've achieved adequate doses. If the patient's not better and you haven't checked the anti-TNF level, you have not proven that that patient is an anti-TNF failure. So don't give up on an anti-TNF without knowing for sure that that patient has adequate levels.
But Asher, I mean, up until now, we've only had 3 anti-TNFs. So I think what we could say is that if you've been exposed to an anti-TNF before, every second biologic doesn't look as good. But we don't yet know really whether that's true, that's an anti-TNF effect, or whether it's true for any drug that we'd use. Because I think, I've been thinking about this a lot for other reasons, and I wonder if after you've been inhibiting TNF alpha for a long time, some of the refractoriness, some of the dose escalation that we're getting isn't just immunogenicity, which I think was what we thought about before, but that really other cytokines, other pathways are now becoming more active, because again, the body isn't trying to do this, this inflammatory process is really directed at something we don't yet know. And so that it's conceivable, and I have no data to support what I'm saying, because we haven't done the switches in the other direction, right? To see if it's really primarily that once you've been exposed to an anti-TNF, things change. And I think that we might see data emerging on that eventually, that there might be a value in starting different biologics or different things before the anti-TNFs.
Right, and there may be in the future a time when we use combination biologics and back off one. I think, Asher, your data on the long-term response of vedolizumab holding that high level was true both of anti-TNF and anti-TNF exposed patients. So that was one that was interesting, and that really speaks to Maria's point as well.
I'll ask a question, Maria and Miguel, just because I want to ask smart people what their opinions are, and maybe it's in here too. And this is coming up more and more frequently. If you have a patient who's done really well, whether it's Crohn's or UC, on their anti-TNF, and they're cool with taking it, they haven't had side effects, but they say, you know what, I hear there are now non-anti-TNF drugs that are effective to maintain remission. I've been well for 3 years, let's keep it to UC. Can I switch from an anti-TNF that's worked for 3 years and you put me on veto? How do you answer that question?
I think that it's someone like that, if they're really in deep remission, all the criteria that Miguel and you outlined, like truly they're great, mucosal looks great, biopsies look fab. UC, I kind of would give them the chance of just keeping them on mesalamine and not even changing them to another anti-TNF, because I think, and I'm making this up, so you can give me a bad evaluation of making this stuff up. I think that UC mesalamines really can work quite well, and if you've already suppressed that inflammatory response for a long period of time, and they've been well for that long period of time, then I think there's a hope. We even know that the microbiome starts approaching more normalcy over a long period of time when you're on effective therapy. So for all those reasons, I might give them a chance with mesalamine. I think what is true is that in the last few years, we've realized these people that have been stable on a biologic, on these monoclonal antibodies for a year or more, we can reinduce them if we need to, right? And someone like that should probably, or he probably could be reinduced if I made a mistake, right? And we took them off and mesalamine didn't hold them. I think it's a little trickier for Crohn's disease. What do you think?
Yeah, no, and I think, Maria, you're bringing up an important point. And all of you sitting in the audience have patients who you do a colonoscopy 4 or 5 years out on an anti-TNF or a biologic, and you say, I can't even tell they've ever had ulcerative colitis. It looks that normal. And the patient asks you, do I really need to stay on this the rest of my life? Maria hit on something incredibly important that we don't know yet, and whether it's the microbiome or something. If we had the absolute predictor of the patient who could stop and the predictor of who should continue, that will be the panacea of treatment. And maybe we can de-escalate to mesalamine. But as Asher showed us in the one study where people de-escalated to mesalamine, in that study, there were a high rate, 50% by 2 years, 80% when you go out 7 years, who had a recurrence. I completely agree with you, Maria, and I have had patients, I've had this shared decision discussion, and we have de-escalated, we're following them, they know the data, and I tell them it's about 50-50 at 2 years. But if we had that predictor, microbiome or otherwise, that's really where I think we will de-escalate in the future.
And actually, one of your excellent questions, actually, the brilliant questions is, do we have any biomarkers that we could use to decide?
Well, I want to, before we go there, I don't
sure.
want to leave the audience with the idea that every patient that you're
No.
starting an anti-TNF, you say, you know what, we'll reassess it 1 year, and maybe we'll take you off and put you on a 5-ASA. I don't think that's a message we want to
No,
deliver.
Right, no, you're right, absolutely
No,
right.
and I
That's
think
right.
these are people 5, 7 years out that we're having this discussion, but the data you showed are pretty clear. The majority are going to flare if you stop their anti-TNF, so I agree with that.
Biomarkers. Are you using any? Let's add to that mix. I think there's so many questions. I'm assuming some of you asked about fecal biomarkers, but any other biomarkers that you might be checking before or after therapy?
Well, I think, with UC, we're tempted to these days, if we buy in, and we should all buy into the idea of mucosal healing is essential. If the patient's flaring once a year, once every other year, you don't want to be doing SIGs 4 times, 5 times in a year. And so when I do that first flex SIG, or down the road when they've healed, or I think they've healed, I'll do a fecal calpro. And I hope that the fecal calpro correlates or parallels the sigmoidoscopy. So I could use that as a surrogate marker, not subject the patient to a SIG every time. I think in Crohn's, that's an entirely different story, a different symposium about a panel of biomarkers. And there's really just been a landmark study looking at pediatric kids with inception cohort. You could identify who's going to have aggressive disease. But in UC, I don't think that we have hard data for prognostication.
Yeah, right. We have a poster, I think it's tomorrow. I'm making a plug for our poster. We and others have been looking at things in the peripheral circulation to see if we could predict who's going to respond to vedolizumab based on, because the idea would be that this vedolizumab is keeping these active lymphocytes out of the gut and leaving them in the periphery. Is there anything in the peripheral blood that would tell us that you're going to respond better if you have these markers? So we're working on that. Perhaps not surprisingly, having a higher proportion of alpha-4 beta-7 cells in the periphery is one of the markers. But the other interesting subplots are that they're not just all CD4 T cells, there are CD8 T cells, there are even some B cells that are also alpha-4 beta-7 bearing. So there might be some nuance in that ratio that might be effective. Okay, what about, I think this is Miguel, what about can anti-TNFs be used together with anti-integrins?
Yeah, so this whole concept of combination treatment. And so today, the answer is we don't have data, nor will the insurance company approve this. Now, we've all found ways around this, and meaning that you're using the anti-TNF for arthritis, and you're using vedolizumab for ulcerative colitis. But that's a rare exception. I dare say most of you in the room are probably not overlapping very long. Where I think we are headed in the future when we talk about especially different mechanisms of action, and especially with the safety of something like vedolizumab, we may use something to induce remission, like an anti-TNF or one of the other agents to come, and we maintain with vedolizumab. Whether we do it sequentially, one for induction, one for maintenance, or in combination. The other part that we don't know is honestly, will the biosimilars ever lower the cost of an anti-TNF enough that a biosimilar anti-TNF is combined with something like vedolizumab? That gets into more of the cost equation. So my answer is today, I have had patients who've overlapped primarily just because they're on one, we get approval for the other, and they get a dose quick, short time together, but I'm not in combination using biologics today.
Right. I think another point though that I've seen happen is people delaying starting, say, a vedolizumab because they just got a dose of an anti-TNF, and there's no reason to delay that. In fact, I think what you're hearing from me and Miguel is we try to have some overlap because okay, one of the questions is how do you switch? When do you feel like switching? So related to that, like when do you...
So I wish we could have drugs that we could combine that wouldn't be blocked by the insurers. I mean, chemotherapy was a big breakthrough when they started having combination chemotherapy in the early 60s, and we're sort of in the dark ages. These are different mechanisms of action, and if you think about it, we do use two very aggressive, well, I don't know if very aggressive, we do use two medications with potent potential side effects. Those are anti-TNFs and thiopurines. Certainly, Vedo has far less toxicity than the thiopurine. So I don't think there should be any inherent objection to using these kind of combination therapies. The real problem is the cost of using them.
Sure. You mentioned something, Miguel, that I want to highlight because there are questions here about the use of thiopurine. You mentioned that you tend to use a thiopurine in the context of anti-TNF, and in that first case, you would tend not to use a thiopurine if you were going to start someone on vedolizumab. Can you explore that a little
Yeah,
bit for
so
our
I
audience?
think it's important, and we didn't really talk about immunogenicity in any of our slides, but when you look at the vedolizumab immunogenicity rates, they're very low, and they're much lower than we've seen with the anti-TNFs, and not just in infliximab chimeric anti-TNF, with the anti-TNFs in general. The reasons for that may or may not be entirely clear, but the point I was making is with vedolizumab, low immunogenicity and very low antibody formation, this is something that I would feel comfortable with monotherapy. What I said about vedolizumab combining with either methotrexate or a thiopurine is if you have a patient who is a high antibody producer to prior anti-TNFs, I think immunologically, and Maria could probably expand on this, immunologically, they're revved up to make antibodies. So this is a patient that I will combine at least for the first year. This is what I've done in my practice. So if Vedo is the third biologic behind two anti-TNFs, especially if they have antibodies to those, not that I'm saying the antibody to TNF goes to vedolizumab, it's just a higher rate of immunogenicity, I will use a combination. Where at least right now in my practice, and this can change over the years, I will use thiopurine or methotrexate in combination with an anti-TNF when I start that. And that's essentially what I've done today.
Any difference in your approach?
No, very similar. I mean, as Miguel said, the vedolizumab immunogenicity is low. I think about using the patient who's run out of options with the anti-TNFs, and they're still pretty active and have a lot of disease severity. About thinking about using a thiopurine purely because it might have its own independent effect.
Sure.
And then I'll have Vedo and the thiopurine. But in general, if the patient's not real sick, doesn't have those bad prognosticators, I'm comfortable, and the patient's very comfortable knowing that they're going to be on monotherapy with a safe drug like Vedo.
Yeah, and I think actually we for the sake of time, we hit some slides, but it looks like, vedolizumab is less immunogenic. In the United States, the FDA didn't let them continue the clinical trial with combination therapy, right? We know that whereas in Europe, they allowed combination therapy with whatever, thiopurines or methotrexate. The rate of immunogenicity wasn't all that different, and I think that that's not just the company's based assay, but even now we have a commercial assay that can measure vedolizumab levels. And I think, we're still trying to figure out what those levels mean, but we like to be early adopters of the technology. We're just trying to figure out how best we can use that. And I haven't really found any patients yet develop antibodies to Vedo. I've had patients have no antibody, no Vedo at trough, but none have had antibodies. What
Right,
about you, Miguel?
and I think to extend on that, I've also not had patients who've had the bad infusion reactions that we've seen with infliximab with Vedo, even now years later. So it seems to be clean and it seems to be low immunogenicity.
That's great. I just want to, before I forget, mention to you that this website where you can download the infographics, we've gotten a couple of nice compliments that you like the infographics, and even more detailed infographics are going to be on the website. We just had to make it briefer, because for the sake of time. People want to know also, a couple of people have asked about new agents. Specifically, they've asked about TOFA. Specifically, they've asked about TOFA and mucosal healing. Any data, Asher?
Yeah, from what I understand, TOFA does have mucosal healing. It's tofacitinib, which has been on the market now for a number of years for rheumatoid arthritis. It's an oral agent, so it's going to be a pill the patient takes once a day. They're not going to be paying the same money that they pay for a 5-ASA pill. This is going to be priced more, to my understanding, in the realm of biologics. It's a small molecule, but it is not immunogenic. It's not a biologic agent. I'm not entirely certain about their long-term mucosal healing data, but they have not only induction data, they have very good phase 3 maintenance data, which is the pivotal data, and I'm sure the FDA is going to give us an answer, I don't know for sure, but probably within the next 6 to 12 months, I suppose.
And I think the TOFA, so the TOFA does heal the mucosa, just to echo what Asher said. I think the question about tofacitinib that we're all wondering is, it does change the cholesterol, so both LDL but also HDL, and there have been some viral infections, especially herpes virus and zoster. So the question is, when we have an inactivated vaccine, which we hopefully will have soon for zoster, will we need to basically vaccinate all of the patients prior to TOFA? Should we be doing that anyway? Maybe. And that's something that I think is something that we would consider. But because it's a live vaccine now, that does limit our ability to give it with biologics and would limit the ability to give it with TOFA.
What about with Veto? Do you vaccinate your patients with anything?
I don't, not before veto, I don't,
Yeah.
no.
That's a patient the other day.
Pneumococcal, I mean, we're talking about, the question meant live vaccines.
Sure, a live vaccine. So, I mean, any of the recombinant vaccines, which is flu every year, and pneumococcal vaccine every 5, those are not live, and you could be using them with impunity in anyone. And actually, even the zoster vaccine, even live attenuated, as you probably know from studies, hasn't really shown a blip in the development of active herpes, but nevertheless, we take that extra precaution. We're hopeful that they're going to come out with a recombinant vaccine. I think we'll maybe have 1 or 2 more questions. One question actually was about biopsy, where to biopsy, but another one was about eosinophils. They've got a patient, fabulous, perfect, mucosa's healed. Eosinophils, your pathologist tells you EOs. What's up with that?
Yeah, so for those in the room that know, one of my colleagues is David Binion, who's taken a big interest in eosinophils, both peripheral and on biopsies. And they're talking about a biomarker that's not yet prime time, but patients who have high eosinophil rates, biopsies and peripherally, are more refractory patients. And the question is why and what do we do differently about this? I would say to answer your question, if you've had a patient who's healed the mucosa, the bowel looks normal, and they're feeling well, but you take a random biopsy and they have eosinophils, that alone doesn't change my treatment at this point. I guess the question will be down the line, if they're having symptoms, do they have some eosinophilic enteritis or colitis that you're picking up? And how we manage that may be different. Budesonide does work very well in the short term, but obviously we don't want to use steroids long term. But that alone doesn't change my treatment.
I think the last question I'll send to Asher's way is someone with just limited proctosigmoiditis. Do you have an emotional problem with starting them on a biologic just because it's proctosigmoiditis?
No, I think your approach and your algorithm for proctosigmoiditis, the only difference is treat them aggressively with topical therapy. Don't let your patient tell you, I won't take topical therapy for mild to moderate disease. They work quickly. A 5-ASA works better rectally than orally. The combination of oral and rectal works well. There's a topical budesonide foam, which has the benefit of reaching up into the sigmoid, but doesn't have the problem of retention when the patient has severe disease. So I definitely would put that in. If a patient has failed all our medications for mild to moderate disease, the 5-ASAs, topical 5-ASAs, steroids, or budesonide, I have no problem going to a biologic. We're treating disease severity, not the extent so much.
Based on the comments that you've sent me, you're turned on to downloading these slides and the infographics. We'd like to thank CME Outfitters that made this possible. We had an unrestricted grant from Takeda for putting on this symposium. And I couldn't have done it without 2 wonderful colleagues that are rock stars in this field. So thank you for being here with us tonight and staying till the very end. Thank you.
Thank you.
Thanks, guys.